Hello everyone, and of course, last time we have studied something about quiet inspiration, but today we will study quiet expiration. What is quiet expiration of the lungs? Quiet expiration is brought about by passive elastic recoil. Passive elastic, like this, recoil of the lungs and chest walls when you breathe out. The term passive indicates that no muscle effort is required. When sufficient air has been drawn into the lungs, of course, when sufficient air has been drawn to the lungs, meet the functional demands. Okay, what happens if the sufficient air in the lungs meet the functional demands? The intercostal muscles intercostal muscles and diaphragm relax. So if they meet the functional demands, the intercostal muscles and the diaphragm relax. There is some elastic tissue in the lungs that will recoil back to its original dimensions. Some elastic tissue in the lungs that will recoil back to its original dimensions. Full stop. There is also a certain amount of torsion set up in the joints between the ribs and vertebrae and in the costal cartilage as they move during inspiration. So during inspiration, there is some amount of torsion in the joints, ribs, vertebrae, and costal cartilage during inspiration. Full stop. As the muscles relax, what happens? These tissues will also recoil to their starting points. What kind of tissues? We talked about earlier. Joints between the ribs, vertebrae, costal cartilage. What happens to them? As the muscles relax, these tissues will recoil back to their starting points. Recoil back. They do not recoil like an elastic band. Of course, they don't recoil like an elastic band. The recoil movement is slow as there is resistance. So slow recoil as there is resistance within the lung tissue. There is resistance with the lung tissue. And the air being expired. The air being expired meets resistance as it leaves, meaning the air leaves the lungs through the comparatively the air leaves the lungs through the comparatively small tubes of the lower and upper respiratory tracts. Comparatively narrow tubes of the lower and upper respiratory. Comparatively. Now moving on to a box that is filled with information. I didn't understand most of it, but that's okay. This book's called Rib Movements. The movements of the joints between the ribs and the vertebral column determine the different movements of segments of the rib cage during ventilation. Again, the movements of the joints between the ribs and the vertebral column determine. So joints, movement between joints of rib and vertebral column determine. What determine the different movement of segments of rib cage? Determine the movement of segments of rib cage during ventilation. To put it in a question and answer form, what determine the different segments of movements of rib cage during ventilation? Again, what determine the different movements of segments of rib cage during ventilation? Answer. What determine it? Rib cage movement. What determine the rib cage movements during ventilation is the movement of the joints between the ribs and vertebral column. Full stop. The figure that is on the right is not very clear figure, ambiguous, illustrates, as the book says, the differences between the joints at different levels in the thorax. So according to this book, the figure illustrates the differences between the joints at different levels of the thorax. There's different levels of the thorax, and each level has a different joint. Each level in the thorax has a different joint. According to what this mysterious book is saying, full stop. Firstly, you must appreciate that movement takes place simultaneously at the joints between the heads of the ribs and vertebrae, at the costal transverse joints between the tubercle of the rib and transverse processes of the vertebrae. Full stop. I didn't understand anything, but I will repeat it. So you must appreciate that movement is happening simultaneously. Appreciate that. At the joints or the heads between the ribs and the vertebrae, they are happening simultaneously. There is also a costal transverse joint between the tubercle, rib, transverse process, and vertebrae. You appreciate that. Full stop. The degree of movement of both joints is small because of the strong ligaments uniting the ribs and vertebrae. And full stop. To repeat that again, the degree of movement at both joints, is small because of the strong ligaments uniting the ribs and vertebrae. So there is strong ligaments uniting the ribs and the vertebrae. Strong ligaments uniting the ribs and the vertebrae. This strong ligament, allow the movement at both joints to be small. Allow this strong ligament, allow the degree of the movement between vertebrae and ribs to be small. First, although the articulations between ribs and vertebral bodies all appear similar on courtesy examination, this paragraph is saying that although the articulations between ribs and vertebrae, there is an articulations, there is joints between rib and vertebral bodies, they appear, these vertebrae and rib bodies appear similar on a courtesy examination. Courtesy examination means fast examination. If you take a look at the articulations between ribs and vertebral bodies, they appear similar. Although the articulations between the ribs and vertebral bodies appear similar on a courtesy examination, this figure on the right, the ambiguous figure, shows that the joints between the tubercles and transverse processes form a series, each differing a little from those above and below, and full stop. This is saying that the paragraph that although on a courtesy examination, fast examination, that the articulations between ribs and vertebrae bodies all appear similar. Articulation between ribs and vertebral bodies appear similar. The figure, that ambiguous figure, shows a different story. Shows that the joints between the tubercles and transverse processes. What is transverse processes? What's tubercle? I don't know. But I think they are the joints between vertebrae and ribs. So between the tubercles and transverse processes form a series, levels, segments. I say this is from me. Each segment, each level differing a little from those above and below. Above the vertebrae and below the vertebrae. Above the ribs and below the ribs. And full stop. In the upper 6 costotransverse articulations, the articular surface on the rib is convex and that on the vertebrae is concave. Let's read this again. In the upper 6, 1, 2, 3, 4, 5, 6 costotransverse articulation. I think this is costotransverse articulation, meaning the articulation between ribs and vertebrae. The upper 6 costotransverse articulations, the articular surface on the rib is convex. The articular surface on the rib is convex. The articular surface on the vertebrae is concave. Only on the first 6 costotransverse articulations. Full stop. The intercostal muscles acting on the upper margin of the shaft on one of these ribs raise it. What does that mean? There is an intercostal muscle. It's a muscle. I think it is a skeletal muscle. Intercostal skeletal muscle. Acting on the rib, acting on the upper margin. Intercostal muscle acting on the upper margin of the shaft of one of these ribs raised. You mean, or this box means that the first 6 costotransverse articulation, there is above them a muscle. This muscle, skeletal muscle, acting on the upper margin of the shaft of one of these ribs that raised it. Rib number 1, 2, 3, 4, 5, 6. There is a skeletal muscle above it that raised it. Okay, I think this is understandable enough. Muscle above a rib that raised it. Full stop. The rib rotating about a long axis running through its neck from the joint at the head to the costotransverse joint. This is not very widely understood. When this box is saying that the rib is rotating about a long axis running through its neck from the joint at the head to the costotransverse joint, this is not very understandable. Full stop. In the 7th to 10th joints, now we have finished from the first to 6 joints between ribs and vertebrae. Now, after we finished from the first to 6th, we now see in the 7th to 10th joint, 7, 8, 9, 10 joint, the articulation or the articulating surfaces are flat, not convex, concave. The articulating surfaces are flat and angled so that the surfaces on the rib tubercle face downward. Again, they are flat and angled so that the surface on the rib tubercle face downward and medially as well as backwards. I don't understand this last sentences, but what I get from this is that the 7th, 9th, 10th, or 7th, 8th, 9th, 10th joints, their articulating surfaces are flat, so they don't allow enough movement. It says here that angled so that the surfaces of the rib tubercles face downward and medially as well as backwards. I don't understand. Full stop. Hence, and hence means therefore, no rotation or no rotation. Hence, no rotation about the axis of the rib neck is possible. There was a rotation about the axis of the rib neck that was possible from the 1st to 6th, but from the 7th to 10th, there is no rotation about the axis of the rib neck is possible. What is this? I don't know. Don't ask. Full stop. Now, at last, to the last sentence, to the last paragraph of this box of ambiguous information, we see here that it is saying the joint surfaces can only slide over each other a little, comma, a movement which displaces the rib principally outward and only slightly upwards. In this last sentence, I will read it again. The joint surface can only slide over each other. Joint surfacing between ribs and vertebrae. Joint surface, they can slide over each other a little. They can slide it. But can they move? I don't think so between the 7th and 10th ribs vertebrae articulation. They can slide over each other a little, comma, a movement which displaces the rib principally outward. That means mainly outwards, forwards, and only slightly upwards. So a small raise and principal forward movement. Moving on to the neck, after we finished this long, boring box of information talking about movement and ribs, vertebrae, articulation, and joints, here we have the figure that we were promised, the movements of the ribs during ventilation. It's only showing T2 to T9, the thoracic vertebrae, T2 to T9. They're also showing the 3rd and the 9th ribs. So 2, 9 vertebrae, 3, 9 rib. And also its articulation, which is not very clear here, but generally it wants us to know that there is an articulation and there is a rib movement and there is 1st to 6th costal transverse or something like that, and there is 7th to 10th movement that is different and much harder. And after we have finished this boring, ambiguous, weird box, we move on to the forced ventilation. What is forced ventilation? We have studied previously the passive ventilation, passive inspiration, passive expiration, but today we are studying forced ventilation, forced inspiration, forced expiration, starting with forced, you guessed it, ventilation. First ventilation in deep, forced ventilation, comma. The capacity of the thorax during the inspiratory phase is increased by a much larger amount by greater movements of the ribs and diaphragm, same as passive inspiration, passive ventilation. Capacity of the thorax during inspiratory phase, or I can say now first inspiratory phase, the capacity increased by a much larger amount by a great movement of the rib and diaphragm as usual. Inspiration, expiration, the main actors are the diaphragm and the ribs. Full stop. They may have to move enough to allow inhalation of the maximum amount of air possible for the individual. They may have to move enough. And by moving enough, they mean extensively. This is for me. Moving enough for the maximum amount of air possible for the individual. Dash, also called the vital capacity. What is the vital capacity? It is the maximum amount of air possible for the individual to breathe in, to breathe out. Vital capacity. First, accessory muscles may be recruited to assist the respiratory muscles. Someone may ask, what is the meaning of accessory muscles? Well, of course, we have said that accessory muscles may be recruited. They are recruited to assist the respiratory muscles, just assisting them. They are not respiratory muscles, they are accessory muscles. What are accessory muscles? Is defined as one of them normally, or is defined as one that normally carries out a particular action, but can be recruited to aid another action. Again, accessory muscle is defined as the muscle that is normally carries a particular action, particular accessory action, let me say, but can be recruited to aid the respiratory muscle, which is another action. Full stop. For example, the pectoralis muscles running between the upper ribs and upper arm normally move the arm. Question: what is normally moving the arm? The answer: pectoralis muscles, which runs between the upper ribs and the upper arm. Very nice place to increase ventilation between the upper ribs and upper arm. Full stop. If the arm is fixed, the pectoralis muscles can then act to pull on the thoracic cage and thus aid inspiration. So, for someone that is running, you tell him to fix his arm. Please fix your arm so that the pectoralis muscle can then act to pull the thoracic or to pull your thoracic cage and aid your inspiration. Just fix your arm and the pectoralis muscle will do the rest. Speaking of forced ventilation, let's start with forced inspiration. So in forced inspiration, the first rib is raised a little by the contraction of the scalene muscles that run from the cervical vertebrae to the first rib. Briefly, again, I will repeat that. There is a muscle called a scalene muscle, or there is muscles, plural, called scalene muscle. They run from the cervical vertebrae to the first rib, from the cervical vertebrae, which are 6 or 7 cervical vertebrae, to the first rib. Scalene muscle. Full stop. These or their attachments to the first rib are shown somewhere in this book. They are attached to the first rib. Scalene muscle is attached to the first rib. That is shown in this book in some figure that we will not discuss today. Contraction of both layers of the intercostal muscles, meaning the scalene and the first rib, moves the second rib in relation to the first rib, the third in relation to the second, the fourth in relation to the third, the third in relation to the second. So, as you can see, that there is a relationship of contraction, all dependent on the scalene and the first rib. That doesn't matter so much. Full stop. The effect being maximum at the 7th or 8th rib. 7th, 8th. When you see the 7th and 8th rib, they are the most strong ribs in ventilation or here in inspiration. I don't want to waste your time much further, so let's continue. Continued contraction of the diaphragm after the point where it can descend no further causes the lower ribs to move upward, but principally outwards because of the constraints imposed by the shape of the costo-vertebral joints. First, this is simply saying after the diaphragm contraction can no longer move because of the maximum contraction of the diaphragm, and it can no longer descend. This causes the lower ribs, I think meaning the 7th, 8th, 9th, or even the 12th and 13th ribs to move upward, principally upwards, principally forwards, but a little upward, principally outwards, and they move upward. Yes, I tell you, they move upward, but principally outwards, forward, because of the constraints opposed to shape. Their shape, why they move principally outwards? Because of their shape. Why they don't move principally upwards? Because of their shape. Costo-transversal, costo-vertebral joints. The erector spinae muscles may contract to straighten the thoracic spine. From this last sentence, you can keep in mind and become a very smart doctor or dentist when you know that the erector spinae muscles contract to strengthen the thoracic spine. Spinae muscles, thoracic spine. Erector spinae muscles contract to straighten the thoracic spine in ventilation. Thoracic spine in ventilation. Full stop. The sternum is pulled up by sternocleidomastoid muscle running between the mastoid process on the base of the skull and the sternum and the clavicle. Full stop. The sternocleidomastoid, everyone knows it. It is between the mastoid process and the base of the skull, the sternum and the clavicle. From its name, sternum, cleido, clavicle, mastoid, sternocleidomastoid muscle. Full stop. When ventilation at or near vital capacity is required to restore hemostasis, what happens when ventilation at near vital capacity is required to restore hemostasis? The pectoral muscles running from the humerus, the bone of the upper arm, which is the same, it is humerus, bone of the upper arm, to the thorax, contract to help alleviate the ribs even more. Again, the pectoral muscles, which we already discussed, from the humerus, bone of the arms, help in elevating the ribs even more. Full stop. The subject will usually fix their arms by placing their hands on their hips to prevent arm movements or grasping a fixed object. If someone is tired and running, he will place his hand on an object like an iron rod or even on his hip, that means on his leg, to allow the pectoral muscle to do its job, raising the lower ribs. And this movement is to prevent his arm moving upward and downward during ventilation. Full stop. Next subject is forced expiration. In forced expiration, the normal elastic recoil of ribs and anterior and anterior abdominal wall is reinforced considerably by contraction of the muscles of the abdominal wall, acting as accessory muscles of respiration. Here we can see that the abdominal wall muscles acting as accessory muscles. Again, the abdominal wall muscles acting as accessory muscles in forced expiration. Okay, and the normal elastic recoil of ribs, normal elastic recoil of the ribs and the anterior abdominal wall also recoil is reinforced considerably. Next paragraph. The abdominal muscles are attached to the lower part of the thoracic cage above and the pelvic bones below. Again, the abdominal muscles are attached to the lower part of the thoracic cage. Lower part of the thoracic cage above, pelvic bones below. What are they? Abdominal muscles, attachment, thoracic cage above, pelvic bones below, pelvic bones below. Their effect is in two folds. Sometimes we say two ways, two features. The effect of the abdominal wall, the effect of the abdominal muscles. First effect, they pull down the lower ribs. What are they? The abdominal muscles pull down the lower ribs, thus decreasing the lateral and anteroposterior dimensions of the thorax. This is the first effect, pulling down the lower ribs, thus decreasing the lateral and anteroposterior dimensions of the thorax. What do? Decreasing the anteroposterior dimensions of the thorax, making it smaller. Also, this is to remember during expiration. Second effect of abdominal muscles. They compress the abdominal contents, forcing them under the diaphragm, which is displaced upwards, thus decreasing the vertical dimensions of the thorax. So again, they also act on the thorax, decreasing its size. Through the second method, or the second effect of the abdominal muscles, compressing the abdominal contents, forcing the abdominal contents under the diaphragm, which is displaced upward. The diaphragm, of course, it's displaced upward, and they force the contents of the abdomen upwards. In general, first ventilation is still rhythmical. Now I will give you a general overview of the ventilation, specifically on the forced ventilation. Generally, the first ventilation is still rhythmical, but each cycle is deeper and faster than the quiet ventilation. We have two ventilations, quiet and forced. The first is deeper and faster than the quiet ventilation. And here we have finished the quiet and forced ventilation. Next, we will talk about miscellaneous information about ventilation. Okay. During inspiration, the thoracic branchial tree. What happens to the thoracic branchial tree? Expands so that the long roots move downward, outwards, and forwards. During deep inspiration, the trachea bifurcation may descend by about 5 centimeters. Again, the first sentence, I don't think it makes much sense. During inspiration, the bronchial tree expands. Okay, we know that. We know that the bronchial tree expands. The bronchial tree of the lungs root moves downward, outwards, forwards. No one cares. But the second sentence of this paragraph is important. During deep inspiration, the tracheal bifurcation. You know what is the trachea, the air tube. You remember it. So the tracheal bifurcation may descend by 5 centimeters. 5 centimeters is too much for the tracheal tube, for the tracheal bifurcation. In quiet ventilation, the central tendon of the diaphragm, we all know it's the central tendon of the diaphragm. The diaphragm has muscles and a central tendon. Okay, in quiet ventilation, the central tendon of the diaphragm moves up and down only about 1 centimeter, whereas in deep forced ventilation it may move through a considerably greater range. Okay, 1 centimeter in quiet ventilation, that's the diaphragm movement, up and down, and 1 centimeter is not much. While in first ventilation, of course, it will move in a much greater range. The average volume of air exchange in quiet respiration is 500 to 600 milliliter, and the normal ventilation rate is about 12 to 15 per minute for healthy adults. Again, average volume of air exchange, 5 to 600 milliliter. Volume of air exchange. And average rates of ventilation, 12 to 15 per minute for healthy adults. Well, by contrast, the normal respiratory rate of a newborn baby is about 40 per minute. So 40 inspiration and expiration, we call it ventilation, like this, 40 per minute. During exercise or stress, the respiratory rate will increase and expiratory volume may approach vital capacity, which is about 4 to 5 liters. We have studied before the vital capacity in first inspiration, and now we know that vital capacity is 4 to 5 liters. We will reach vital capacity on exercise or stress. Of course, the vital capacity will depend on age, sex, body build, and overall fitness of the individual. Ventilation may be forced externally during artificial respiration, a skill described in the box we will discuss later. It's a box of information, okay, which all members of dental team must practice regularly. What do they must practice regularly? Simply, they must practice artificial respiration. We will discuss artificial respiration in the next subjects to come in the next lectures. But now we, of course, have studied the forced expiration. We have studied many information about it. We have understood it. Later subject, we will continue on talking about speech ventilation, artificial respiration, and we will finish this chapter. Thank you for listening and see you later in the heart and pericardium and mediastinum, chapter number 12.